Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this expert briefing for the media, which is hosted by the Johns Hopkins Bloomberg School of Public Health. Today's experts will address what we know and don't know about long COVID. We will also discuss how we can prepare for potential surges as the US surpasses 1 million COVID deaths, a once unfathomable number, and as cases rise in other parts of the world. Please note that participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. First, I'd like to briefly introduce our two speakers. Dr. David Dowdy is an associate professor of epidemiology at the Johns Hopkins Bloomberg School of Public Health and a physician with Baltimore Medical Services. He serves as the track director for infectious disease epidemiology at the Bloomberg School and has studied epidemiology of multiple infectious diseases, including COVID-19, tuberculosis, and HIV. Dr. Priya Duggal is a professor of epidemiology at the Johns Hopkins Bloomberg School of Public Health. Her primary research is on the intersection of host genetics and infectious disease. She leads two COVID-related projects, COVIDgene and COVIDlong. We will have time for questions following our speakers' remarks. The procedure will be as follows. We will take some questions that have been submitted in advance of the briefing and some questions from the Zoom chat. If you have a question, please enter it in the Zoom chat addressed to all panelists. Please enter your name, media outlet, and question. We hope to cover as many as possible. Just a note that participants will be muted during this briefing and it will be recorded. Dr. Dowdy, please go ahead.
Thanks so much for moderating, Ellen. I'd like to start with some comments about the pandemic as a whole. From mid-February to the end of April, COVID deaths fell by more than 75% across the globe, the most dramatic and sustained drop in deaths since the beginning of the pandemic. As such, numerous announcements have been made that the pandemic is entering a new phase. For example, on April 27th, Dr. Anthony Fauci declared that the US is out of the pandemic phase. However, in the last 3 weeks, deaths have plateaued and cases are starting to rise again. And some authorities are warning of a potential wave later this year that could infect 100 million Americans or more. Through all of this, more than 2,000 people are still dying of COVID-19 every day across the globe. The US is likely to experience its millionth confirmed death this week, although the number of excess deaths of all causes due to the pandemic is already well past that number. Of particular concern is China, which has seen a number of large outbreaks in major cities like Shanghai and Beijing. Probably over 200 million people in China have no exposure either to the virus or to an effective vaccine, meaning there is a very large population at risk. We should also not forget that an estimated 40% of the world's population, over 3 billion people, are still not fully vaccinated. Many of these people are either children or in poorer countries with weaker healthcare systems. Getting vaccines to everyone who needs them is still a very high priority. Another prominent trend relates to COVID-19 testing. Since most testing is now being done at home or not at all, numbers of confirmed cases are no longer a reliable indicator of the burden of COVID-19, as they are a dramatic underestimate of the total number of new cases. That being said, rates of hospitalization and death in the US are climbing only very gradually, despite substantial rises in cases, suggesting that the average case of COVID-19 is becoming milder. But this is not just a story about the average case. People with weak immune systems remain at great risk and deserve extra protection. And COVID-19 is still killing over 300 Americans every day, meaning that about 1 out of every 30 deaths in the US is still due to COVID-19. Dr. Duggal will speak to the burden of ongoing symptoms in those who have recovered from COVID. It's important to remember that vaccines are still highly effective, even against our current variants. For example, among people over 65 in New York, those who are fully vaccinated are still more than 20 times less likely to be hospitalized than those who are unvaccinated. In summary, we do appear to be entering another phase of this pandemic where vaccinated people with strong immune systems are experiencing milder illness. But cases are going up again. People are still dying of COVID, and we can't rule out the possibility of a major wave in the coming months. Thank you.
Thank you, Dr. Dowdy. Now we will hear from Dr. Duggal. Dr. Duggal, please go ahead.
Thank you, Ellen. So globally, it's estimated that 1/3 of individuals who've had COVID-19 experience long COVID. Long COVID, as defined by the World Health Organization or the WHO, as new or persistent symptoms 3 months after your initial infection that last for 2 months or more. What's very striking is that individuals who tested positive for COVID-19, 3 to 5% have long-term symptoms where they feel they cannot normally function in everyday life. If we think this could even be 1%, it would affect 800,000 people, given that 80 million have had a COVID-19 infection in the United States. The first question we've asked is who's at risk? To date, global studies indicate that both men and women, all races, those hospitalized and not hospitalized, those with mild, moderate, and severe infection, those with and without comorbidities, and all ages are at risk. Given this, it means that really no one gets a free pass. Beyond just having initial or persistent symptoms, people are reporting mobility disability. This means that they now have trouble walking short distances or going up a single flight of stairs. And it's not yet clear who is at greatest risk for these particular disability issues. Definitely people who already had mobility issues or who are older, and those who are hospitalized are at risk. But we're also seeing younger people and those that were healthy before their infections and those who had mild infections. So what can we do? We can avoid infection or reinfection, and we do this by vaccination and boosters and masking and social distancing when you're in higher exposure situations. At the moment, there are no specific long COVID treatments, partially because we don't know the mechanism of long COVID. If it's extra virus, then perhaps antivirals will work and should be considered in trials. If it's an immune response reaction, then how do we control that initial immune response to be strong enough to keep you out of the hospital, but not so strong to wreak long-term symptoms? If you do have long COVID symptoms, we advocate talking to your primary care physician and with them seeking care from one of the many long COVID multidisciplinary clinics across the United States. This will provide you with specialists that can address a multitude of symptoms and get you the best care available. Long COVID is real. If you have it or have symptoms, please seek care. It's not yet clear if the vaccine and boosters protect you from long COVID or if different SARS-CoV-2 variants result in different long-term outcomes. But we do see that fewer people who were vaccinated report long COVID symptoms. Thus, we advocate for vaccines and boosters as a layer of protection against severe infection, but also against severe long-term outcomes. In summary, despite our huge success in reducing the number of hospitalizations and acute infections by masking, vaccines, social distancing, and all of us coming together, we now face a burgeoning problem of long-term symptoms and outcomes that affect multiple organ systems and can occur in both mild, moderate, and severe infections. This problem will affect individuals and society in both health and economics as we add another layer of complexity to this pandemic.
Thank you, Dr. Duggal. Now we will take questions. And a reminder, please enter your questions in the Zoom chat with your name, media outlet, question, and to whom you'd like to address your question. Here is the first question from Jason Gale at Bloomberg for Dr. Duggal. Since long COVID has reduced the ability of many sufferers to return to work, weakening their financial security, how should governments balance the need for immediate social and economic supports to help those affected with the need to understand the pathobiology of long COVID?
I think that's a great question and one that I think we need to grapple with as a country. The first step was actually declaring long COVID a disability. And I think that was a good step in allowing us to recognize it as a real syndrome, a myriad of symptoms that can result in people having these long-term outcomes that can affect the economy overall. But I think now we also have to think about if it really is even 1% that say they're functionally disabled as a result of this, we're looking at almost 1 million people and perhaps even more as more people continue to get infected that can't function in everyday society. And so this is a real question of how we should handle it, what priorities should be made, how will we handle employment? There's a lot of questions that need to be asked that have moved us beyond just are people getting hospitalized and dying.
Thank you, Dr. Duggal. Here's a question from Tina Say at Science News for you, Dr. Dowdy. Some data seem to indicate that Omicron is not milder than pre-Delta variants and that BA2 may be more virulent than BA1. What can we say about virulence and how that may or may not matter going forward as more people are vaccinated or get COVID and with the waning immunity?
So that's a great question, Tina. What I will say is that the average case of COVID-19 does seem to be getting milder, but this is probably more because we as a population are building up immunity, not because the variants are necessarily getting milder on their own. And what this means is that for people who are still unvaccinated, don't have that immunity built up or have weakened immune systems, this virus is still a very dangerous and deadly one. So we are seeing cases get milder over time, but it's probably more because of the immunity that's building up, not because the virus is getting weaker, if you will.
Great. And another question, you had mentioned the rise of at-home tests and many states no longer reporting data on a daily basis. Seems to be a real dearth of information about what is actually happening. Is there any reliable source of data out there, Dr. Dowdy?
So no source of data is perfect, but we do have multiple streams of data that can be helpful. Hospitalizations are not perfect, but are certainly better than case counts now because most hospitals are still reporting hospitalization data. Deaths in areas like the United States are still useful, but a lagging indicator. We also have new data sources coming like, for example, wastewater surveillance. So we do have multiple threads of data. None of them are perfect, but when they're all trending up together, we can get a sense that there's a new wave coming, for example.
Great, thank you. Here's a question for you, Dr. Dowdy, from Denise Rowland at the Wall Street Journal. What criteria would need to be met, in your opinion, for the pandemic to be over?
Yeah, so another great question. I think the first thing to remember is that COVID-19 as a disease is not going to be over. Just like influenza is not going to be over, nor is HIV, for example. It is reasonable to think, when should we consider this no longer to be in a pandemic phase? And I personally would think that could be reasonably considered when the burden of illness due to COVID-19 is along the same lines as that of other infectious diseases like the flu, for example. So I think that would be a reasonable benchmark, but we're not there yet. And it is important to recognize that even though the pandemic may move into a new phase, COVID-19 is not going away.
Great, thank you. And a follow-up from Denise at the Wall Street Journal, Dr. Dowdy. One place where cases are surging overseas is South Africa, but the government doesn't plan to reintroduce restrictions because scientists predict, based on neutralization assays, that BA4 and BA5 will lead to a surge in cases, but not in hospitalizations and deaths. To what extent is South Africa a model for living with COVID in the long term, i.e. strong surveillance and fast analysis by scientists to predict the impact of new waves?
So South Africa certainly has been a model in terms of strong surveillance, and I think that they are engaging with the scientific community in a helpful way. I worry a little bit about predicting the course of epidemic waves on the basis purely of neutralization assays, but I don't think that's really the full story. I do think that we all have a lot to learn from South Africa in terms of strengthening our surveillance and making sure that those surveillance systems are linked both with the scientific community and with the policy community. I do think that the future of this pandemic in South Africa and elsewhere does in some ways remain uncertain.
Great, thank you. And here's a question for you, Dr. Duggal, from Judy Graham at Kaiser Health News. Can you tell us more about COVIDlong? What is the status of this project? Are there early results? If so, what do they show? And when are results expected?
Great, thank you for that question. So COVIDlong is a study that we're aiming to have of 25,000 people in the United States. We're happy to say that we have 15,000 enrolled to date, and our goal really is multifold. One is to really quantify how many people have long COVID in the country and who has it and what are those risk factors. So some of the risk factors we see are that it's pretty much almost everything. It's not as clear cut as it was for those who would get hospitalized. I think most striking, and we're consistent with other reports, is that we're seeing that it spans the ages, it spans the sexes, it spans comorbidities, and it spans initial infection being varied. We're also really interested to see what those symptoms are with regards to long COVID and how that relates overall, both the heterogeneity within long COVID, and there's a lot. So some people experience having a loss of sense or smell that persists for 6 months or longer, and others now have new cardiac outcomes, including congestive heart failure, right, that have debilitated them in a completely different way. So it's our ability to quantify that as well. But we're really interested also in understanding the people who have lived through the pandemic and didn't have COVID. Even if you didn't have long COVID, you didn't have COVID. Because we're all living through this pandemic, and as a result, we know that there is a lot of stress and anxiety that could induce some disorders and disease. And we're interested in trying to understand what might be happening overall to each and every one of us. We hope to have initial results on mobility and disability out this summer.
Great, thank you. And for you, Dr. Dowdy, Amy Lunde at the Hub at Johns Hopkins University. With cases on the rise, are we looking at a potential summer surge where masking will be reinstated? Or are we never heading back in that direction thanks to vaccines, even if not enough people are getting vaxxed and boosted? And a follow-up, speaking of boosters, are we heading towards boosters for everyone eligible under 50? Are we going to see shots that have been adapted to fight new variants? And what metrics should we be looking at now going forward as the sign of trouble ahead? Are case counts, which are up again, the number to watch? Is it still hospitalizations?
So a lot of questions in one. I think it's important for us to realize that in some ways we are already in the midst of a surge. There are indicators that the amount of transmission happening in this country right now, while not the same as it was this past winter, is at the levels that we were seeing during the Delta wave and almost that of winter 2020 to 21. But what we're not seeing are the same rise in hospitalizations and deaths. So we're seeing a small uptick, but not the same tremendous rise that we've seen with some of these previous waves. So I think in some ways this is encouraging in that we're starting to see a divergence between the number of cases and the number of hospitalizations and deaths. But it's also a little bit discouraging that we've been through all this and we're still seeing a flat line and an uptick in the number of people getting admitted to the hospital and people dying. So I think we are seeing a surge. Whether that's going to require us to go back to more restrictive policies, I think still remains to be seen. Regarding boosters, I do think it's important to highlight the need for those at greatest risk. So those whose immune systems are weak, those who are older, to make sure that you've been vaccinated, boosted, and gotten that second booster or additional shots. We're starting to see also that the older population, the immunocompromised populations are again accounting for a larger and larger fraction of people in the hospital and people dying. So those boosters are very important. Whether or not we're heading for boosters for everyone under 50, I think still is a question that remains to be seen. Vaccines are still highly effective for those with intact immune systems against getting really sick, and I'm not sure that we're at a point of saying we need to have another booster shot for that population just yet. We are expecting to see vaccines. Moderna has announced that they're planning to put together a bi-vaccine, so one that would have both the old vaccine formulation and a new Omicron-specific formulation together in one shot. We're hopeful that will come out and will be effective, but won't be here for a few months. And as far as what metrics we should be looking at, I do think that hospitalizations remain a useful indicator. Deaths, of course, are a good indicator, but lagging. Case counts, we can see trends, but we can't trust the absolute numbers. But we can, with all of these, again, triangulate multiple different sources of data to see if things are going in the right direction or the wrong one.
Great, thank you. Super helpful. And here's a question from Arthur Allen at Kaiser Health News for you, Dr. Duggal. What's your best explanation for why some people in a household will get sick and others not, given similar vaccination, prior known infection levels? Innate immune differences, different exposures to past coronaviruses, and you can both take this on if you'd like. We'll start with you, Dr. Duggal.
Yeah, sure. So we definitely see a lot of heterogeneity within a household, and the reason for that is multifold. Some of it is exposure. I think we have to start right there. If you're able to not have someone exposed in a household because they're able to distance themselves, or you have good ventilation, that's a reason that someone wouldn't also get infected in a household. Some of it is your own immune system, and that immune system is varied in what it's seen before, if you've been infected before, when you were vaccinated, which variant you saw before, and how it reacts to what you see. And also your own comorbidities and your own health in general, and how you would respond to an infection. And some people are able to fight off some of those initial infections and others are not. So we're not surprised to see it. We see it with lots of infectious diseases, that not everyone within a household gets infected, but it continues here with COVID.
Great, thank you, Dr. Dowdy. Anything to add to that?
No, just to reiterate what Dr. Duggal said, that this happens with other infectious diseases. We know with the flu, some people get really sick, some people really don't. We will continue to do our best to find the sources of those disparities. But on some level, we also all just need to maintain some degree of respect for this virus, recognizing that we could get sicker than the person next to us.
Great, thank you. Here's a question from Ava Joy Burnett with WJC for Dr. Duggal. We are now seeing outbreaks once again in schools. Should schools return to virtual learning during an outbreak, or are there instances when in-person learning can resume? For you, Dr. Duggal.
Okay, so as I think that every school district and every school area has to consider their best options. I think the one thing we've definitely seen as a result of this pandemic is how much it differs from within a state and between states and in specific areas. I also think that we have some autonomy that we exert ourselves in having our children mask if they so choose, or having them take some of their own precautions. But I don't think that with the recent surges, there will be necessarily a change in what is happening in the school systems. And that includes virtual learning. I think that if we can have children in schools, we're going to do our best to have them in schools. That being said, we should still take every mitigation necessary and available to us to prevent infection in schools.
Great, thank you. And here's another question for you, Dr. Duggal, from Sonia Azad at WFAA TV in Texas. Is there any research you can share about long COVID and mood disorders, anxiety, depression, even sleep problems? And what do we know so far about the connections? And what can you suggest for people who are trying to find treatment or relief in the short term?
Yeah, that's a great question. I think we have to remind ourselves that we're living in the middle of a pandemic, and there is a lot of stress and anxiety on all of us. And as a result of that, we've definitely seen an increase in anxiety, depression, and sleep disorders that have occurred in our general population. Some of that may be the result of the virus itself. We do know that the virus has neurocognitive effects and neurologic effects that may affect those particular outcomes. And some of it may just have to do with the fact that we have an increased amount of stress due to the pandemic. Like with anything, if you're experiencing those symptoms, if you have trouble sleeping, if you have increased anxiety or depression, we ask you to seek care and to speak to your physician and to tell them and remind them that you've had COVID. That will help in that discussion.
Great, thank you. And for you, Dr. Dowdy, a question from Liz Boney at Sinclair Broadcasting Group. Can you speak more on death rates from current surge, climb in cases compared to previous surges? Now, are we better at treating it? Are the current variants getting less severe? Are the vaccines protecting? Why are cases up, hospitalizations rising, but deaths are not right now?
Yeah, so that's a great question. And I think what this highlights is the different forms of immunity that we're developing against this virus. So we are building up as a population immunity against severe infection, though we're not necessarily building up that much immunity to getting infected at all. So the average case is getting milder over time. We're seeing hospitalizations rise only about 25%, whereas case counts have gone up almost threefold. I do expect that we will find deaths to go up by, again, this 10, 20, 25% over the coming 3 weeks or so, because deaths usually lag hospitalizations, but we're not going to see them skyrocket, at least not yet. I do think that treatments are playing a role, antivirals are playing a role. Vaccines have played a huge role in developing the immunity that we have now. But I think that what we're probably seeing is overall the average case becoming milder. Hospitalizations are not going up as much as case counts are, and deaths will be following hospitalizations by a few weeks.
Great, thank you. And for you, Dr. Duggal, from Kevin Loria at Consumer Reports. With so many people affected by long COVID, what sort of transformation does our healthcare system need to provide adequate care and treatment? When people are experiencing symptoms they believe to be related to long COVID, where should they first look for care?
No, that's a great question, and one I think that is worrisome overall in the healthcare industry that's already been burdened by this pandemic. The first place that anyone who is experiencing long COVID symptoms should go to is their primary care physician. That's someone that you hopefully already have a relationship with, who knows you, who knew you before you had COVID and knows you now. If you don't have a primary care provider, we encourage you to seek care with a internist, someone who can see you on a general basis and assess you. Overall, there is a general concern of who will be qualified and able to treat the burgeoning number of patients that we're going to have with long COVID. It's reassuring to know that long COVID multidisciplinary clinics have emerged across the country, mostly in cities, and that there is an intent to increase that number as available with trained physicians and healthcare workers.
Great, thank you. And another question for you, Dr. Duggal, from Lynn Peterson at Trends in Medicine. Is there a reservoir for the virus that is responsible for long COVID?
That's a great question, and one we don't yet completely have an answer on. It has been suggested that perhaps a viral reservoir exists, and that's what causes long COVID. That yet hasn't been shown. We do know that individuals in specific organs may have traces of the virus, meaning they have particles of the virus that are left, but not necessarily a reservoir. But there is the possibility that we may see in future studies that emerge. At the moment, that's sort of an unknown answer.
Great, thank you. And likely our last question for Dr. Dowdy from Jim Morelli at Fox 25. Recent data from the UK Health Security Agency shows a dramatic drop in effectiveness of all COVID vaccines in preventing symptomatic illness with Omicron and its subvariants. But there was less of a drop with the Delta variant. Does this say anything about the long-term viability of currently available vaccines, given the apparent evolutionary direction of the virus? And how do you persuade the unvaccinated, given the data on fairly rapid waning, to get immunized?
So this is a great question. I think the answer is current vaccines still work. They don't prevent you from getting a mild infection, but they do prevent you from getting seriously ill and getting in the hospital, including against Omicron and the most recent variants. So for people who might say, well, this vaccine isn't going to keep me from ever getting sick, that may be true, but it's going to prevent you from getting in the hospital. It's going to potentially even save your life. And again, that has not waned with the most recent variants. So our vaccines are still working. They won't prevent you from getting a mild case, but they will prevent you from getting seriously ill.
Great. Thank you to Dr. Dowdy and Dr. Duggal for your presentations and insightful answers. We will email the links to the resources mentioned today and share it in the chat. And with that, I'd like to say thank you again to everyone for joining us today.